Hello, from CMD Nigeria. This is Heart of Healthcare podcast. My name is Izini, and with me is
Big now back.
we are your hosts.
I want to share quickly a story about what happened to me during housemanship. So, the facility where I did my housemanship, for some, I don't want to go into what happened back and forth, but somebody in the very high person in the admin did not want me to work in that hospital. So I was not given accommodation. For 5 months, I was living in the call room. I chose a call room. I found a way of making the call room very convenient. It was an abandoned call room. I made it very convenient for me to stay, and that's where I was staying. Each time a doctor on call is not found in the hospital, the nurses know where to find me.
Oh, wow.
So I was backup doctor for every doctor. That every doctor on call that does not show up, if they have an emergency, they come to find me. This particular day, at night, I was in my room, in the house officer's call room, and the doctor on call could not be found. We had this patient who ran into, she had a lot of problems, severe abdominal pain, was passing, she was both passing blood and she was vomiting blood. So she had some form of gastrointestinal bleeding, massive dry bleeding. So since they couldn't find the doctor on call, the nurse on duty rushed, found me. I came out. Let's see how we can, sort out all of these issues. I think so. What we tried to do that night was, to start with, she did not have a patient relative to care for her in the hospital. So that night, the nurse on duty were trying to find a way of helping the woman out, because nobody was going to pay bills for anything. Nobody was going to help her to the bathroom and all of those things. We literally called any contact on her phone that looked like a relative, either friend, brother, sister, pastor, anything that she saved that looked like either a religious brother or sister. Everybody who picked our call either said that he did not know her so closely or that they were not too fine. So everybody gave one excuse or the other why that person was not going to show up. Unfortunately, the patient died the next day in the morning. She died around 9-10 a.m. By like 11 o'clock, about more than 30 people showed up as relatives. In fact, some of them were threatening that they were calling their relatives to come because that they wanted to sue us for killing their sister. These were the same people we called the previous day to come and attend to their patient. True life story, I was there. In fact, one wanted to assault me. One of the senior doctors had to say, no, you cannot do this, and all of those things. So now that begs the question, because we always advise our brethren to go the extra mile. This is us trying to go the extra mile for a patient who did not have a caregiver, and we did the best we were able to do for her, given what we had at that time and the resources at our disposal, just for her to die. And more than 30 people are showing up, and they are throwing lawsuits here and there, and we're even threatening physical assault. My question would be, what do you think? I know every doctor has a story of how you were compassionate on a patient, relative or for a patient, and it bounced back at you or something in one way or the other. So what do you think about that? How far is too far? If we say let's go the extra mile, what mile should we stop at? Should we go 2? Should we go 3? Or should we go 4 miles? What do you think is in it?
I have my own story though. And honestly speaking, I actually went a lot of miles. Like I really did the whole extra things. And regardless of that extra I went, just like you mentioned, most times they blew up in one's face. In fact, it actually blew up in my face so many times that I lost to myself that I will not be caught in this position again. See, in one of those episodes where we discussed and I said I do not like clinical medicine, this is another reason. Because you go all out for a patient and they turn around and bite you. And the way they will do that, you will not even believe that these are people who you wanted to help. These are people who you wanted to help. These are people that you made efforts to, you went out of your way to provide support, maybe help them at the blood bank, help them at the pharmacy, get drugs for them, and then they disappear. And then the management is looking for who is the doctor that signed on this, who is the doctor that did this. And so sometimes I feel that extra, you don't even know when you go. You don't know. Sometimes you just don't know. You just go. You and then after going, I realize, oh my God,
I've gone
extra. So for me, I would think that sometimes you don't know when you go that extra because it's something you've signed up for. We're humans. And again, if we really call ourselves believers, we tend to go more than we plan to go. We tend to go more than we plan to go, and it's not that easy. So really, for me, my own personal opinion, I know that it can turn around to bite, but then sometimes you go the extra. But since we have with us Dr. Fervent Idoko on, it's good to have you. Hi.
It's great to be here. It's great.
Hi, Fervent.
So, one of the things that I have never really liked about medicine is it's not like other disciplines. Medicine is not like other disciplines, really. Medicine is the only place, hospitals are the only places where you can, and we're talking about clinical medicine here, of course. Hospitals are the only places where you can show up and ask for services without money.
Real. Fact.
Everybody expects that the doctors, the nurses, the pharmacists should be compassionate.
Because you swore an oath. You signed up for it.
There's this thing that, you have to care for human life. And we agree that we have to do that. And interestingly, medicine as a system, the healthcare system, runs on money, amongst other things. And of course, there are structures in place like any other organization that allows things to happen and make things to happen. With the story that you shared, you would have not been in that issue if you simply follow the protocol. You are not supposed to be there, so I'm not going to be there.
Exactly. I was not on call.
Yes,
So in that case, they would say you're not compassionate because they are knocking on your door. There's no doctor available. You are a doctor. Come and help this situation. And you're saying, I'm not on call. Anything else to happen should happen. I'm not on call.
And they can't, and you can't even be what's it called?
Not liable.
Yes, you're not liable because you're not on call. But then,
and that's the interesting thing to me now. It's if we want to be compassionate, which is what we encourage, not just sympathy, not just empathy, but being compassionate. Now, I was looking up the dictionary definition of compassion, and it's saying compassion is that you feel what the other person is feeling and you want to do something. Empathy doesn't necessarily mean you want to do something, but I really understand what you're going through. And compassion is saying, I understand what you're going through and I am ready to do what I need to do to help you get through this phase. And if you really want to be compassionate, I wonder if you can do away with getting into trouble. If you can escape getting into trouble.
That's interesting. So where do you draw the line? Because you have ethics. We have to practice within the provision of ethics, and you will now have compassion. Where does compassion comes head to head with ethics? Because you have to get, so for example, is it ethical because of emergency, to move out a patient who is dependent on oxygen to go for a procedure when you know that the protocol will require that you will have to wait for a stretcher, you have to wait for a what do you call it now?
Which of them?
No, the oxygen that you have to move with. There's a name for it. A mobile oxygen, oxygen set. Yeah, so where do you draw the line between saying that my patient is dying, I'm compassionate about it, I want to move ahead and all of those things, and waiting for protocol? Protocol says that you have to move this patient with a mobile oxygen. Where do you draw the line so that you don't put yourself into trouble?
But my question, this question you're asking, just to add to it, I even want to know, Because the more time you spend on that patient, waiting for the stretcher or waiting for whoever it is that's supposed to do the next job, time is going. The patient is losing time.
Yes.
And that patient can die. And the aim is to save the patient from dying.
So you swing in compassion and you bear the the consequences.
I mean,
I honestly think that's what it ends up becoming.
Do you get?
I mean, that is why I don't do the clinical medicine.
Oh, you don't do the clinical medicine. Can you
But
imagine
again, that means we are losing brethren from practicing clinical medicine because of compassion fatigue.
But
they can't draw a line between what is ethical and where compassion should. Because
It's not that. It's not.
See, sorry to cut you short, but I feel that if we had a working system, these things will not be an issue. It's easier to do things knowing that, this person is going to respond. There's always going to be an oxygen cert, a mobile oxygen cert, ready to move a person, right? That somebody is going to, those at the pharmacy, those at the blood bank, they do things right? They don't waste time, they don't delay, they are not, what's that word again? I'm trying, where they are. Yes, at their posts. Why I'm saying this, let me just tell you something that happened during my house job when I was in O&G. So usually when patients come in, you are supposed to take a blood sample. Of course, everybody here knows that is not the doctor's job at that time, to take blood sample.
Let's not argue that, but continue your story.
But sir, that's not the doctor's.
As I said, let's not argue that, but continue your story.
Okay. Let me leave it. So now, the patient is supposed to pay before coming to the labor ward. Now it is, I don't know if it is, but we set lines. Do you know that as a doctor, as a house officer, I always carry things, extra things. There's nothing you don't find inside my bag. And the idea is to reduce turnaround time, right? So that I'm able to respond to my patient, because this person can be in labor. This person is already pushing. And I need to set line, I need to take a sample. We need to be careful. And if you check, this patient cannot even afford gloves. This patient does not have gloves, has not even paid for a pack. And they rush this patient in. Now, sir, my question, to that your question, I'm hoping that you as a medical elder will answer it.
I'm not a medical elder.
Oh my God. But my question is it okay, is it right that I have those extra things in my pocket to take a blood sample, send for investigations, and be sure that this patient, knowing that I do not have the whole the PP wears to attend to this patient. We don't have it in the hospital. I don't know if this patient is okay. I don't know her stand. Sorry, not her stand. I don't know her
status.
Yeah, her status. She doesn't have a glove. I have to go and borrow from somebody.
Mm-hmm.
So, is it ethical that I go ahead and, take a blood sample, take gloves from somewhere else? Can that other person I'm taking from not come and say something? Can that person not have an issue with that? Is it right?
Okay, so I will add some layers to this conversation.
Okay, sir.
When you are applying compassion, you are not only applying compassion on the patient alone. We see from the stories of Jesus that Jesus did not only apply compassion on one person. Sometimes he looks at the entire picture to apply compassion. So when you are applying compassion, there's something called compassion on the system itself. Is out of compassion. I like what Fabian said. Compassion is you don't just feel the pain, but you have the need to do something to change it. We need to have compassion even of our system so that we can find the courage to change it. You are also looking at compassion to your family. Ezine, you have a family of your own. If you contract HIV from that medical procedure because you were rushing to help the patient in an emergency and you get a needle prick and you contract HIV in the line of duty, or maybe the patient, since you give an O&G situation, what if she came with Lassa fever and in order to save the baby alive, you decided to swing into action and you contact Lassa fever? What happens to your husband? What happens to your baby? So, you have to look at compassion on a broad, from a broader perspective. It's not just the patient in front of you that you are fixating on. You are looking at compassion. How does your action affect other healthcare workers? Does your action expose them to, to litigation? Does it expose them to diseases? Does it expose them to other things? How does that affect your family? How does that affect the institution in and of itself? I think these are larger conversations that you have to bring to the table before you will begin to know how far is too far in application of compassion. If it's something that can be sorted out locally, no problem. We have borrowed diapers from one baby after speaking with the parents because another child does not have a diaper. That does not go beyond, or it doesn't go off bar, because at least we have some understanding within the SCBU. But exposing yourself in the name of compassion to getting Lassa fever, and you will return back to serve because you were on call that day, you have to attend to more women in labor, and you have to return back home to your family. That's your act of compassion. Is it now compassion towards who now? So there are layers to the conversation. We too have to help the system hold itself accountable while applying compassion. And I think that is where ethics come to play. You have to know what are the laid down guidelines within the sphere of medical practice. So there are laid down guidelines in managing one particular condition. If by textbook, you are required by protocol to have to wear PPE, if you are, that's fine. I like your example of patients who run away with hospital money. By protocol, it is mandated that they have to pay before they are able to get blood. But you took out of goodwill, you decided to step into that picture for them. And at the end of the day, they went home without paying. And some of them don't have money challenge. No, they don't. In fact, I've had patients that come up to say, we did not ask you to do so.
Oh my God.
Yeah.
Yes. So you have to help the patient to be responsible.
It's one of the things I was just thinking about here now. Yes, in this whole conversation around compassion, we want the doctors to be compassionate, and really that's what we are pushing for. But I think we need to also begin to ask patients and their relatives to be compassionate too.
No, it's part of compassion to help the patient and the patient relative to be compassionate. It's part of compassion. Yes. It's part of compassion to go the extra mile to contact the patient's own relatives to come and attend to their patient. So compassion is not only giving money and breakfast to the patient every morning. Compassion doesn't stop there. Compassion is seeking solution to the problem.
I think she also mentioned something important too, about the way patient relatives treat you sometimes in the hospital. Yes. It's almost as though they come with a transactional mindset,
yes,
and you're expecting the doctor to go beyond the transactional mindset. There are a lot of things you do to help the patient, and when the patient gets better, they will appreciate it. But if for any reason they don't get better, they will look back at all those things you were doing that you felt you were being compassionate, and they begin to want to fault you on those grounds. And that's really where I'm coming from. And maybe we should also, this is not to stop, this is not to say, if the patient is not compassionate, the doctor should not. We are going to be doing what we are supposed to be doing. But I think maybe a word should go out there, because I've heard several persons, maybe in the private hospital scene and all of that, feeling like doctors are just collecting money from their hand. I think I've overheard somebody saying something like, if you come my shop, I will collect money for your hand. So I don't go hospital now. I don't enter in shop. You want to collect money for my hand. So to him, it feels like what is happening here is just an everyday regular business transaction. They just want to take money from you for whatever. It's not, nobody is trying to think about the life of the patient, how she's feeling. To them, it's just about money. But we know that many times that's not what it is. Especially when you go to public hospitals, especially in public hospitals, and even in private hospitals. If it's not a very big one, where they really charge, most smaller ones they don't have the leverage to really charge that much, are still operating within tight margins.
Mm-hmm.
So that's just something I wanted to add to the conversation.
All right, so maybe I should ask Ezine, do you think, or don't you think that engaging patients in their own care can still serve as compassion and will reduce the compassion fatigue a doctor can get? Secondly, do you think that helping other healthcare workers to do their jobs properly out of compassion for the patient, do you think that will reduce the compassion fatigue for the doctor? And that will also help with ethical issues. At least let's get a middle ground.
Okay, to answer the first question, people will be people. I mean, human beings will be human beings. So, maybe not everybody would respond to you engaging them in the care of their patient, their relative now. But I think it is important. I think it cannot be overemphasized that anytime you see a patient, you should engage them. Let them know what they are dealing with. You should also tell them the outcome. As a doctor, I think we should always tell patients the outcome of whatever it is we're doing. Oh, this is how it's going to be. Is a 50-50 expectation. Is this, is that. In fact, even when I think we are very eager to always say, don't worry, she's going to be fine or he's going to be fine. And sincerely, sometimes, of course, we know that anything can just happen within a twinkle of an eye.
So don't give false hope?
Yes, don't give false hope. And apart from not giving false hope, engage the patient relative and say, this is what you can do. This is how you should do it. Currently where I'm working, I think we're really big on educating the patients about what is expected.
True. So that means we have to stop, by our training, we have to stop the paternalistic approach to healthcare.
Yes.
We have to stop the paternalistic approach.
Yes.
Doctors are overriding decisions and they're landing themselves into trouble. In the name of
Serious
compassion.
trouble.
So we have to stop paternalistic approach. Thank you. A response to the next one.
Then the other question. I do not think we should help other health workers in their work.
I'm not saying we should help them do their work. I'm saying that we should motivate them to do their work.
Oh, motivation. I agree. I think we can motivate them. But then we should not overstep our boundaries in that motivation.
By that, what do you mean? Because you have to befriend people so that you get a relationship with them.
Oh, yes.
That you motivate them. So by boundaries,
yes.
Where do we
By boundaries, I mean, in as much as, yes, I'm friends with you, but let's not forget that, you are this and I'm this.
We will have that conversation.
No, what I'm trying to say is that, of course, with the way things are happening currently in the society, where everybody wants the title of the doctor attached to their names. I know, yes, you said we'll have that conversation some other time. Yes. But it is very imperative that we mention it. In as much as, yes, I'm the head, but I should not forget that I need every other person on the team to work, to exist. I mean, look at Joe Jesus has been on strike and that strike was called off. But we really could not do much. We really could not, because these patients need to be monitored. And who are the people that would monitor them? Nurses.
Nurses are not on strike.
No. Then I don't think they're still on strike now.
NAM has not been on strike. NAM is not part of JOSU.
Oh, wow. Wonderful. But some of them... Oh my God, Dr. Bondi, why are you happy? But you know what I'm trying to say. That sometimes nurses, when they're on strike, we can't do anything. Even when Joe Jesus is on strike, you can't pay. You can't make some payments in some places. There are things we can't do. Of course, so we don't run alone. We need the team to work. Yes, you should be friends with these people, but then let us also not forget, because sometimes human beings being human beings can overstep the boundaries and try to push their work to you. Even when you are friends with them, especially when you're friends with them.
The only thing I'm hearing is that when you emphasize teamwork, you reduce compassion fatigue. The rest of the things you are saying, I'm not hearing it.
No, sir. Now that is your own. That is what you think.
This is not what I'm thinking. It's what I'm hearing you say. Because we will get to those conversations of where to draw the line.
But to add to
hopefully
the discussion on compassion, I'm also thinking something. I think the reality of the fact is, if we want to be compassionate, it's not a very straightforward thing. First of all, not even every doctor is compassionate. I think maybe we should even mention that.
Compassion is a very straightforward thing.
True, I agree with Dr. Bondi.
We are just talking about where do we draw the line now.
Exactly, and we're saying you draw it at ethics, you do teamwork, and you refuse paternalistic approach. This is us providing solution to an existing problem.
Yes. Yes, that's just a fact. But see, like I said, human beings will always be human beings. We do not have no, it's just a fact, sir. We're not going to have everybody on 100% all the time. Even you cannot be on 100% all the time.
Because I mean,
Except-
on ethical lines, let's say there's something a nurse is supposed to do for whatever reason. They are telling you they are short-staffed, like in the public hospital, and
yes.
the current nurse hands is on something,
Yes.
and the child is right there in front of you.
Yes.
Are you going to insist on protocol?
No, pass the bulk forward. Who is the next most senior person that is supposed to move the administrative block? You pass the bulk forward.
yes, so,
You stop paternalistic approach. You're not a Superman. That's what teamwork is.
I just
You
want
pass
to-
responsibility to who it belongs.
Okay. So maybe the case here is that we should stop applying compassion just at the bedside. Maybe we
No,
should
you don't stop
compassion
applying
to-
compassion. You do not just you see.
We should not-
You have to draw the line between compassion and Messiah complex. Because in compassion, we sometimes can run ourselves into heroism and Messiah complex, and you run into trouble for it. It is out of compassion that instead of walking away, I'm calling the next senior person to tell the person this is what is happening. You pass the ball forward.
So it will not be considered that this person does not have compassion
Exactly.
when they don't.
You
do
went the extra
anything.
mile. Yes.
So okay.
You can even help the nurse system, who is the most senior nurse, up forward. When you have a problem in a unit, you move to compound office. This is you doing something. You're not doing nothing.
Okay.
Yes.
This is an interesting one. I mean, it's changing my understanding of what compassion is supposed to look like.
Yes, to what it is really.
It's changing my understanding. Well, I am just imagining the typical scenario you see sometimes, and then the mother is by the side there begging you to do something, and you can do something, but you have to call the person.
You really can't do something if you,
You
look at
really
it
can't
properly.
do something because you have to know your limits. You can only be compassionate within the sphere or boundaries of your limits. Do you understand? Because so if the regulation says that a nurse will have to get movable oxygen and move a patient for procedure on protocol, it is a nurse. If you as a doctor decides to do that, when the chips are down, you have broken protocol.
And not just that, you're not attending to your
You're not
patient.
exactly.
You've left your
You've left
own
your own work
duty.
unattended too.
Yeah.
So you will be fault for leaving your own work unattended because of so. We need teamwork. And like what Ezine says, you cannot run away from teamwork. Maybe we should begin to look at our leadership as doctors. Whether we've been able to motivate our team very well. Have we been able to carry our people along very well so that everybody does his own work?
And perhaps bring a mindset, a long-term mindset
Exactly.
to the concept of compassion.
Exactly.
And foresee potential issues and begin to try to address them. So you're not
Before
in
the
another way.
situation.
True.
Do we only teach our doctors compassion? Do we go ahead to teach other team members compassion? Or is compassion only limited to doctors? Of course. Because if you, the doctor, is compassionate, if the rest of the people are not, what do you think the management will look like?
I think that another thing that the management can do is to organize some of these things and teach it and remind people again. So these are solutions that we can give. You know, where we have such trainings, we are reminded, we stage we do role plays and see it, do role plays and say, oh, what is expected? I think people do not forget when they role play, except you're just being evil, plain evil.
We should recommend that to CMD in Nigeria. We should.
To conduct more. I know we do have some conversations around compassion and all of that.
We should teach what compassion is and what it is not.
Exactly. And where should we? This should be something that should be taught. I think IFL can have, but then how many persons attend?
No, I think this is a
IFL?
conversation beyond IFL. We have national conferences. These are big conferences. We have HCF, Healthcare Fellowship, that has joined other, sister fellowships. we can even, take proposals to them.
Yeah, perhaps influence
influence
what
other,
happens in enemy
nurses
and
fellowship.
conferences and bring them
Exactly.
up
We
there.
talk about. We must know what compassion is and what
What is
compassion is
not.
not. What is heroism?
Where
What
to
is
draw the
Messiah
lines.
complex? Where do you draw the line?